So this is meant to be a thought-provoking break for the next lab, which Dr. Lewis is going to do on osteotomy techniques to put and to show what we're doing. And this is meant to be reflective. And could somebody bring a microphone, maybe Mark, to Dr. Shaffrey, because I'll call upon him on the far side of the room. Make sure he doesn't fall asleep. Do we always have to fuse? So I don't have any academic conflicts, but I am a consultant for two companies. One is Extant and the other one is Limiflex that produce devices I'm going to talk about. I'm also a consultant for Globus, but I want to point out that there's a potential conflict of interest. As you saw from Dr. Lewis's excellent lecture and all the preceding ones, we can positively change lives with what we do. And who knows what this woman in the 14th century and what her life was like. But it's amazing. She apparently got into her mid-40s with this deformity. And as a general business model, the spinal column is a miracle of embryology, and it's a miracle of alignment and function. I personally still think, and this is my political agenda, that should be recognized as an organ system. It fulfills all the requirements of it. It's not a musculoskeletal, it's not a neurologic structure, it's an organ system with multiple failure points, attachments, and functional units that can unfortunately fail. One of my personal mentors was a man who stood right here, Professor Jean Dubuisset, and he's an amazing man, and he basically changed spinal deformity surgery by looking at it in this three-dimensional fashion. This is an oft-showed slides. But here's my concern. So all of us have learned these angles, and these angles are real. They reflect truth. They reflect something that we would like to help us understand the patients, but the real understanding of what happens to patients if we do something versus not remains somewhat elusive. And I always show these two patients. I'm not going to bore you with all the little details, but just assume that this is in principle without a gotcha, a realistic nutshell description. For a 58-year-old patient at the time, back pain, unable to be active. And here's patient B, 62 years old, back pain, unable to be active. Neither patient has neurology. And I'll ask the master himself, Professor Chris Shaffrey, which patient will become a surgical patient? One of the two will be, one of the two will not be.
Well, by their selection or by the appearance and radiographic criteria?
Just the little stuff that I give you, both are faithful appearances in your clinic.
B,
have no neurology.
B will be the surgical patient.
And why would you say that? Just on the limited stuff. There's no gotcha, there's no tricks here.
Yeah, I think that the patient A appears to be an untreated idiopathic scoliosis. The patient B seems to have far more degenerative changes than the patient A does. There's a more pronounced thoracolumbar kyphosis. I think the lumbar lordosis is somewhat reduced. And from what I can see here, there's developing lateral asthesis, lateral translation. It looks like L3-4 with those. So there's several different factors to me that would make that person be more compelling. And the patient B is much more likely to have spinal stenosis, foraminal stenosis, and other problems that would lead me to saying that's going to eventually become a more likely surgical candidate.
I cannot argue with that. Here's the patient A. I treated her surgically. This is in my UW days. She was a lawyer. This was a life-changing condition for her, and she, in retrospect, said,
"It's not worth it.
I wish I had this surgery. No, I wish I had this surgery done way earlier," because she was one of those government attorneys hidden away in a back office, shy, unhappy with life, just really not happy. She's very grateful. She has followed me here. She has endowed things. She is a wonderful patient, very, very happy. There's some numbers. She had actually an intraoperative complication. She did have cardiac ischemia during surgery without any big bleeding, and we actually found that she had hidden coronary artery disease. She got a open bypass procedure, and then a week later, 2 weeks later, we finished the surgery. So, and this is patient B, and actually I followed her recently also, so the follow-up is much longer. It may help to understand that she is of French origin, and she is happy, and she just comes back to be checked, and she is very happy. She's truly happy. This is with one of our former fellows at UW. And these are some comparisons. This is what struck me about this case when we started collecting these more effectively. clearly, the one patient kind of has settled down a little bit more. It's the ugly X-ray. I fully concur with Chris, but she's as happy as can be. The numbers are pretty much the same. So for the patient A, she would have, had she been able to turn back the infamous wheels of time, elected to have that surgery way earlier in life, and who knows what her life would have been. She remained unmarried and childless, and patient B has actually had children, and she is active and travels. So we all want the best for our patients, but sometimes prediction capabilities of ours suffer, and we just don't have the right prediction capabilities. One other game that I love to play is that from Vancouver, and our dear friend Marcel Dvorak is very ill these days. Many of you know that, and our hearts and thoughts are with him in our prayers. He's very strong in the face of very bad disease. But this is an epicenter of excellent academics and clinical care, just like Toronto and Calgary and other places. But Marcel's a dear friend to many of us. And so they did a great study on publishing what the risks of major spine surgery are. And just by a show of hands, what would you at UCSD say is the complication rate? 1, 2, or 3? Just shout out a number. 1, 2, or 3? 3? To your left, OHSU. Give me a number. 3. Major surgeries. One more poll. Let's go to Dr. Kent. What do you think the number of complications is that they found? They followed patients for 2 years with a study nurse, just like what we did at UW with Chris Shaffrey many years earlier. 2, 25%. Chris, you know that this is an award-winning paper at the time?
Well, it's 5.
It's 5, and 5 it is, 87%. They actually followed every single patient. And the key points were, again, they had a mishmash of patients, so not just deformities. But the key point was that actually the hospital database only recorded about half to 2/3 of the complications. And there were far more complications, some of them very serious, that just eluded a standard retrospective assessment. So there are a lot of complications. What matters is different. Interestingly, and I put that slide out just for brevity's sake, patients' perspective factors that led to satisfactory outcomes regardless of most complications dealt around anxiety and depression, which was a study done in Dallas by Carlos Bagley et al. With pretty well powered, over 180 patients, 2-year follow-up. And the main predictors were anxiety and depression. So globally, adult spinal deformity is on the rise and a reflection of aging population and comorbidities. But we as spine surgeons are thrown into the mix here. And again, I took that slide up, but Dr. Chris Shaffrey gave an absolute must-see lecture on spinal deformities. Is it worth it during the recent Resident Fellows course? And you can see it in our library. And thank you, Chris, for coming for that and giving that excellent lecture. So clearly, there are substantial complications, and if you believe our Vancouver colleagues, probably most patients have some complication. And you heard great lectures on the main problems of infections, proximal junction failures, non-unions, rod failures, neurologic symptoms or deficits. Now, this is what I'm seeing right now as an aging spine surgeon. I see some developments where the age of the old open surgery somehow has become an anachronism and is falling by the wayside, although we saw just absolutely phenomenal surgeries done by Dr. Lewis in his last lecture. It's being replaced by MIS. Now, there's a clear-cut kind of very cool aspect of, quote, damaging our patients less and making surgeries less painful and recovery faster. For me, again, when we have a complex spine and we're trying to rebuild it and you're supposed to build a new model, doing it open is hard enough, it's delicate enough, but there are those who say they can do it through a bottle, and that's kind of cool and it's amazing. It's never the same detail, but there's artistry involved in that, no doubt. The other point that I'd like to make as an orthopedic surgeon is anywhere in orthopedics, if you were to go to a board exam and told somebody that you, for instance, put your pins for an external fixator straight through the muscle outside of a life and limb-endangering situation, you'd get fired on the spot. You would not pass muster. The intermuscular plane has always been a factor, and we permanently change the muscles of the paraspinal muscles, and those of us who revise a lot of MIS surgeries see that in abundance. So this is not a major problem. Now here's my first conclusion. So spine deformity surgery and any fusion surgery, as Dr. Shafi keeps saying, is a potential deformity surgery, should follow the following 3 tenets: effective and lasting decompression of compromised neural elements, meaningful realignment and stabilization of the spine where needed, and a solid fusion in instrumented areas. Lest we forget, the hardware does not lead to fusion, but something called metalusion. What I'm seeing a lot now are patients with these Uzi approaches where there's a myriad of incisions around them. And yes, they'll get a posterior midline open exposure to revise what has happened. And this is all kind of taken from Dr. Wiltsey's very, at the time, appropriate thought that you can do stable L4 to S1 fusions for isthmic spondyls of lower grade with a paraspinal muscle approach. The other consideration for lateral and anterolateral procedures is this. This was created by one of our fellows, Dr. Perigodolias, and his colleague, Dr. Gerstmeier, is sitting here, and they recreated out of normal MRI scans beautiful 3D reconstructions of the lumbar plexus. Those white things are the discs in between, and you can see how the lower you go, the more there's a meshwork of nerves in there. It's a miracle for me that you can do, especially trans or far lateral approaches without causing neural injuries. And that's not even considering the myriad of other organ systems that are there. So in skilled hands, it's a good thing. But we've had ureteral injuries that I've never seen before. We've had abdominal wall dysfunctions that I've never seen before. And the actual neurology is probably way higher than what some people have postulated. It's probably more like 20%. It's probably 100% for the acute phase. And learning to understand a variety of neurologic deficits like genitofemoral nerve impingements or iliac-inguinal neuropathies is a whole new ballgame. But there's a lot going on up there. And again, doing these anterolateral surgeries is something we should do with a lot of thought. Now, why am I mentioning this? With less invasive surgeries and more technology focused, there comes this temptation to kind of turn everybody into a deformity surgeon. And we see far more of these cases where there were, I think, 6 level far lateral cages placed and percutaneous screws placed, not to the pelvis because that's much harder, as we heard earlier today. And again, it doesn't look all bad in the beginning. But for the first 2 years, you can kind of get by with this, and then the predictable things happen. The patient basically has non-unions, falls apart. The bottom is a non-union, and the patient becomes increasingly unhappy, and by their own accounts, way worse than before. And this was eventually then treated with a major revision surgery with a PSO. I want to credit Dr. Hart for this nice save, and he was willing to share these slides with me. But he did a single open midline approach and did a very nice PSO, and the patient actually became quite happy with this. So the problem was the execution of that first surgery was well intended, I'm sure, was conceptually okay in some ways, except for the pelvis fixation. But this was done by somebody who is not a deformity surgeon, somebody who had a good experience with less invasive surgeries and thought they'd stretch the boundaries more. And I can't blame them. It's a new game, and it's an area where they have, quote, early adopters, and the learning curves are more tolerant maybe in some eyes. But these are complex conditions and complex surgery. So the tendency to do more fusions seemingly has risen. This is a patient we revised recently, and he came here for his half-year follow-up, and this is, again, a life-changing event. This patient had a series of 4, quote, MIS surgeries, leaving that individual with an L3 to 5 fusion, later an L2 to 5 fusion. You see the left-handed series of images. And that person was a senior executive in a very successful, larger company in this area here. And he actually retired due to chronic back problems. He had given up until a friend told him to come to our center. And we saw him, we revised him with quad rods, with eccentric osteotomies, all IDOs. And the patient now is actually half a year later wanting to go back to work. Just a little picture, because we didn't have that before. This is what an eccentric IDO looks like at L5S1. And you can achieve a very nice bone grafting and rebalancing at the spine where it matters most. Again, I defer to Dr. Lewis's previous lecture to see how you can kind of restore coronal balance. And again, Dr. Theologus gave a very nice presentation about that also. But rebalancing a spine from this is very good. If you look at the source images, again, what struck me was this was not a deformity surgeon who did these inner body cages. This is a well-intended, probably well-trained surgeon, but the spine was basically being thrown off more and more, and then it was the patient's fault that the patient didn't get better. So spinal deformity is a complex disease that is multifactorial, that I think with multiple factors in there really has to be checked. You heard great presentations earlier about how to try to mitigate some of those. But between risk factors, osteoporosis, discal ligamentous rebalancing, and neurologic structures, there are so many unanswered things. Just even the proximal junctional failure factors. Dr. Hart with ISSG put together a very nice score of risk factors for this. And we now know that deformity reductions, female and osteoporosis, are a really bad combination for these things. And we also know that a loss of muscle tone is a fact of life. This is a patient who was fused elsewhere. She continues to beg me to fuse her to her cervical spine. I did neither of these surgeries. And I continued to refuse them, but I followed her over time. And again, she's clearly not listening to my very strong rehab requests in terms of building up her muscles. Sorry, the degrees vanished, but you can see how she's letting go of her thoracic spine and letting her spine hang forward. This is a known physiologic factor of aging. So these are, again, these problems that we've simply not resolved. How to fix the spine, we can do a nice job, like in the 76-year-old patient who had a breakdown above her fusion, and we were able to straighten her out in the lower thoracic spine after much deliberations. But how long that'll last, I don't know. So this is something that is unresolved, and junctional repair measures and buffer measures have been batted around. And going to the upper thoracic spine, as we heard earlier as well, is a pretty big deal because these patients have to be particularly carefully coached. And again, I'm going to skip through these things. But major spine surgeries are a major undertaking. And the big problem is that fusions beget more fusions. Now, here's a thought-provoking thing, and I'll ask for since he has a microphone, Dr. Shaffrey, as an opinion leader in our field. In the NHS, who arguably have the best database in the world for a national healthcare system, they did a Get It Right the First Time initiative, and they found that if you did not do more than 40 surgeries for deformities a year, you should probably not do them due to the rise in complication rates. What do you think about that?
Well, I think there's something to be said. And I think a lot of these complications aren't you as the surgeon, but it's most people are doing more than 40 of them have the entire system. ICU care, anesthesia, they do things. For example, and I've joked around about it. I'll have one of the anesthesia residents, I'm doing a 1-level anterior cervical discectomy, and they said, what dosage of TSA do you want? Do you want your 50, your 55 protocol or your 110? For one, I say, I joke, I said, maybe I have the reputation of losing some blood, but we probably don't need that for a 1-level ACDF. But there's places people say, oh my God, my anesthesiologist won't give TXA, my anesthesiologist won't do this. Having things like Rotem or TEG to go and check your coagulation status, I'll do it. So I think that what happens is, I don't think this is necessarily a combination of the people that are doing it, but I think it's more a little bit, as all of us do things more frequently, we do them better. And I think that you usually, if you're doing more than 40 a year, you've got a system in place that allows you to do it more safely. So I do think that in general, and the question is, what is now a major deformity? It used to be a T10 to the pelvis was considered a major deformity. But just as you showed for some earlier cases, there are a lot of people out now who are regularly doing a T10 to pelvis and may do that 40 number. For me, if it involves a 3-column osteotomy, that's generally that's major surgery. If it's more than 13 levels, I think that's major surgery. So I'm not saying people shouldn't do it, but you need to be aware of your own, your own capabilities to do that. So that's a long-winded answer. So the answer is, I agree in general purposes, but sometimes these things are shown in in self-serving roles that, hey, there should be 6 centers in the United States that do all the deformity, and I don't think any 6 centers could potentially do all that. But I think it means that you got to be, you're not doing your patient, a fairness. Although all of us, when we get out of our training, everybody has a, 5-year ramp up where you have to get to be doing 40. So, and what always concerns me too is, from a medical legal perspective, that's one of the things people will ask is, okay, how many of this operation have you done for the plaintiff's attorney? And then they'll say, can you document, in fact, that you have done 40 of these in the last 3 years, okay? Then you get yourself in trouble, because if you provide documentation, that you've done it, they're gonna look through and then ask your hospital, what's your level of complications, and again to go do it. So I just say you have to be within your you have to be really realistic within your capabilities, and you have to drift out towards doing it. So I think that volume is a positive factor, but it's not the only factor.
Well said. And again, these were center numbers, so this is not individual surgeons, but 40 was their number. Now, here's for me the real problem, the real crux of the matter. So we have more and more enabling technologies, from easier hardware, more tech-specific things. We have more image guidance systems, even robotics to make screw insertion and other things easier. But this is a patient who is 78, a retired nurse, and she has a ubiquitous problem that all of us in spine care see literally in multiple minor variations in every clinic, right, Chris? I mean,
yeah, that's every day.
Every day, every time. And so this patient has degenerative disc disease, and I'll just say she has moderate stenosis at 2-3, but pretty significant stenosis at 3-4, probably some trifoil canal, some facet arthropathy at 4-5 with a minor slip. No major deformity. She has the small little curve. Chris, what would you do? Would you give this lady a T10 to pelvis fusion? In your hands, this is a very quick surgery. This is a run-of-the-mill surgery for you.
I would probably do a several level interlaminar decompression. Again, I'd like to see the long cassette films and whatnot, but
this is what I could get from an outside hospital.
It does not look like she needs a major surgery. So if I was convinced, I would probably do something like a couple trials of epidural steroid injections. If they got a great response from the epidural steroid injections, I would do a decompression alone. I'm a big believer that for people with a little bit of deformity, and to me, I think the crossover point is, are any areas that have a spondylolisthesis or lateral listhesis. She doesn't have that. If you have a curve more than about 20 degrees, that usually doesn't work well. And if you have to do a facetectomy to be able to correct the problem, you probably have to fuse at least the level of the facetectomy. So for me, from what I can see here, this would be a person that I would just do an interlaminar decompression. I think that works just well, and I think that you always can go back with interlaminar decompression because you're leaving all the midline structures. If you have to go back and do a fusion down the road, if the scoliosis progresses, you could do it. But she's an interlaminar decompression for me.
Drumroll. So an outside surgeon decided to fuse her, gave her a total of 3 spine surgeries, fused her, I think, L2 to 5, partly minimally invasively, partly percutaneously, then changed it to open because some of the levels didn't heal. 5-1 didn't heal, so she got a fusion, eventually ending up with an L2 to pelvis attempt at a fusion. And she came with excruciating, not just back pain, but leg pain, because one of the screws had actually gone, it's not visible on this one, I didn't pull the right image up, but she actually eroded into the canal with one of her upper screws. So we have a problem now. This patient, in my opinion, and this is again a problem that Dr. Schaff and I had. Are we ready in the lab, Gary?
About 3 minutes.
3 minutes. I'll hurry up. This was a problem patient. So I had the savior complex. I took her to the OR. She had multi-level thoracic spondylosis. After careful discussions, decided to go to the upper thoracic spine. I did the shaft rebanding, north end. I did hooks, did not touch the ligaments on the top. Thought we'd done a nice job. I think we lost about 800 cc's. We did IDOs above. We tilted her back, revised her rods. Everything seemed to be fine, but again, Bob Hart calls it the curves of the small curve. I fully agree with Dr. Shaffer. I would have never fused this lady. I would have decompressed her. I would have optimized her. I would have done anything non-surgical. So this patient, literally like 3 weeks later, after an uneventful, difficult in terms of personality management hospital stay, got a cholecystectomy and came with a dislocation of T2-3. I swear that entire rostral segment was completely intact. She probably had been, have you seen this, Chris, pulled up on her arms when she had surgery and she's dislocated? I had that once at Harborview that you may remember. This patient was neurologically intact, and I had another one here after a knee replacement about a half year out. Have you seen these dislocations rostrally after?
Well, I said earlier, and you may not have.
So, yeah, I was there. You had the banding and the subluxed.
Yeah, and 2 levels above.
Yeah.
And I think it is, again, it's a ligamentous stress concentration problem, particularly with people that have poor bone quality. But Yeah, I mean, this used to happen before I banded them. It always happened right at three, at T3-4. And now that I'm banding him, it's happening. But again, it's 2, 3, 4 years down the road, and usually after some minor trauma, something that they were lifting something heavy and they felt a click or a pop or something went on. But yeah, I've had this happen, and that's one of the reasons, where I've said previously, if I can realistically stop in the lower thoracic spine, you don't get these catastrophic, paralysis things, at least, not many of them. If you fail, let's say you stop at T11 and it fails at T10, they may have back pain, they may develop kyphosis, but they don't become paralyzed. You have people that failed in the upper thoracic spine, and I've got 2 or 3 of them walking around that are paralyzed. They were doing something, felt a click, felt a pop, felt something happen, and so and again, it's usually these multiple revision, poor bone quality, neuromuscular problems, essential tremor, mild Parkinson's. They're the ones that, at least in my hands, seem to have these catastrophic failures.
So we were able to save her by fusing up to T1, and she's okay for about a year. She's not fallen apart, but she's developed a number of medical problems now. But the point here is that fusions, especially long fusions, begets fusion disease that is then very hard to stop and curtail. And again, this is her latest, where she's starting to sag forwards with the head. So couldn't we have done something different in her? Dr. Schaffer said yes, he would have done a multi-level decompression. And again, saving the midline is a big deal. We have a paper that's still looking for a home somewhere where, especially in the junctional area next to a fusion, saving the levels is actually a really big deal because it does seem to reduce the amount of adjacent segment decay. So alternatives, and this is where I get into conflict of interest. I want to reiterate that because I've worked with both entities and I'm a consultant for both. Doing quality decompression surgeries is a lost or losing art. Doing those very elegantly and cleverly was to preserve the midline is an underestimated benefit, and ripping out the posterior midline, which has nothing to do with stenosis usually, is an unnecessary invasion. It certainly burns the bridges for later on. So here's a case of mine that I did, and I'm not particularly happy. This is, however, a 20-odd-year-old follow-up. So I did this when this patient was in their 60s, and she's a former gold medalist in the Olympics in skiing. And she's from the old world, and I did a fusion with ray cages, which I still think are an amazing mechanical thing, but they were not exactly great for lordosis. But she came literally 20 years later, and she had significant adjacent segment disease. Chris, you got the microphone. What do we do with this now? So she has significant burnout of 2 discs above. She has neurologic symptoms. This is an exercise fanatic to the present date.
Yeah, I don't see any instability. So I would have, and again, a little of this depends. If it's all neurology, if it's all neurogenic claudication, I would consider decompressing the 2 levels above it. If they have severe back pain, then I'm reluctant. I'll usually extend the fusion. And how I differentiate that is I will do facet joint blocks. If they say, okay, 80 or 90% of my pain got better with facet joint blocks, I'm going to fuse them, versus doing an epidural. And to me, if the epidural markedly improves symptoms, then I lean towards a decompression. If it doesn't really help much, and facet joint injections help a lot, then I'm going to do that. And I probably, again, I'm a little concerned. Looks like she may have an old compression fracture.
Yep.
Then you're suddenly really looking into bone quality and whatnot. I think the reason why you have this enthusiasm for the supplementation devices is I think something in the middle probably is the ideal solution for this kind of problem.
Dringle teed it up. He doesn't know this lecture, but this was a day surgery. We discussed this. Obviously, she absolutely did not want. I treated her non-surgically for her T12 burst fracture, by the way. This is a day surgery, and she's as happy as can be. She's a year out and counting, and she's returned to full activities. I was a bit apprehensive about that because I don't know how these devices work in the long run. I've used them for about 8 years, but preserving the midline at the upper junction level at L4 is actually a godsend because I could anchor this device in there. And again, you can see these actually move, and she's as thrilled as can be. It's an in-between buffer zone. So can't beat this. 79-year-old farmer wife, very difficult spine, a lot of stuff going on, an old in situ fusion attempt, may or may not be healed. She kind of trucked along because she's a farmer person. In life, she had this L4 to S1 onlay in situ fusion plus decompression. You can see an MRI, there's still a reasonable canal, surprisingly good foramina. She has an L2-3 transitional zone. Long story short, you see the thing here. I did a day surgery on her. This is her standing films. I have some flexion extension films also. We did not over-distract. We just built it up a little bit, and I've learned a lot of fine points in this, but she's as happy as can be. This is, again, a day surgery as opposed to a T9 to pelvis fusion, which I just a couple of years ago would have probably thought is the only way out of this. Chris, any thoughts on this?
No, I think that, again, that I think it's something that adds to the armamentarium. We all know extension of fusion, extension of fusion, extension of fusion usually leads to more fusion. And the question is, for example, we showed this in our indications conference. I would say half of the people would say what she really needs is an L5 PSO because she's flat. And that's what's causing this breakdown. But in a 79-year-old, I personally think that's crazy. So I think that, that what you did, if that goes and buys 5 years, who cares if you have to do that, 5 years down the road at another level up the spine. So I think this is a technique that adds to the bucket of things we can do, and it's an intermediary between a decompression and a fusion.
Three more cases. Deformity. This lady actually is just a dream, 76-year-old. All these patients are phenomenal, very motivated people. No back pain. By the way, there's a whole industry out there now of patients who don't want fusions. She absolutely swears she has no back pain. She has a previous laminotomy at L4-5. We studied it with a CT myelo. It's just an MRI. And again, same story. We actually did we identified that there's a single level of significant stenosis. We did this kind of a device. And she is like 8 months out right now and returned to completely normal life. She never got back pain. She never had back pain before. I told her, and again, this is one of those things, this is something that I don't know because historically I would have talked to her about a fusion. Fractional fusions in these patients. Chris, any thoughts on, let's say, an L4 to S1 fusion or pelvis fusion in this setting?
Yeah, I mean, I'm usually if I can isolate the symptoms to the fractional curve, that's something that I routinely will do. And what's happening is a lot of times, particularly with the degenerative scoliosis, if you realign the fractional curve, and I think that what Steve Lewis was saying, at the end of your procedure, if L4 is horizontal, a lot of times that upper scoliosis seems to not progress. So I like doing a limited fractional curve correction if legitimately you feel confident or I feel confident that the vast majority of the symptoms. So for me, if I have somebody with an L5 radiculopathy, I will very regularly do an L4-5, L5, S1 T-lift. That's my go-to. And if someone's really got profound loss of lordosis, depending on their age, I might A-lift them and do the back. But that's a very common intermediary procedure. And again, I tell people, I quote, if I do a fractional curve correction, there's a 50% chance within 5 to 7 years I'll have to do something more. But usually if you give them a great response and elimination of their leg symptoms, they're usually pretty happy, and they've got a fair degree of trust in you that makes any further treatment easier. Alexis, I saw you grab the microphone, so I'm sure that you have a good feeling about this.
I feel the same way that you do in terms of addressing the foraminal stenosis at L5S1. Many times in the lumbosacral fractional curve, it's the lateral recess at 4-5, but it can be the foraminal stenosis as well. If they are quite a bit elderly, I would say at over 75, but even over 80, I try to avoid an anterior, irrespective of their sagittal plane. It's hard to do a nice laminoforaminotomy and adequately decompress the foraminal stenosis at 5-1. So I do think that fusion probably is necessary in that situation. But you have to really lay the crepe, because that elderly patient, poor bone quality, if you fuse them flat, it can start to add up. But I agree. In the patients who have concomitant mid-lumbar lumbosacral fractional pathology, if it's just coming from the lumbosacral junction, just addressing that, patients are very happy.
Just out of curiosity, would you take her fusion to L3? She has this lateral subluxation. She has this fractional kind of a collapse L4, L5, S1. Would you fuse her higher to L3, or where would you stop?
Yeah, that's a great question. If she had, and you can do a combination. So if it's just 5-1 foraminal stenosis, I may just fuse that and decompress 4-5 lateral recess. If she has no neural compression at 3-4, then I don't think you would need to address that. But if you fuse her 4-1 with that lateral listhesis, then you should be talking to her about possibly coming back at a sooner time for possibly decompensation of that area.
So just in the interest of balance, I want to point out not all is perfect. This is a different scoliosis patient, rheumatoid arthritis, grade 1 degenerative spine. You get the picture, one level, clearly neurogenic claudication. I did a device with her. It's just 3 months out now, something like that. She has no more neurologic symptoms. She still has the same back pain, which is left lumbosacral back pain. She'll need both hips fixed at some point in time. She has both knees that are arthritic. Again, she still has back pain. So we had this conversation. I said, do you want to have a big fusion? She said, absolutely not. I'm happy with my nerves working. So that was, just wanted to be balanced and not just be a company person. Complication rates of these devices are between 3 and 15% within 2 years. In comparison to fusions for 1 or 2 levels, this comparison systematic review was favorable for these kind of interspinous device spaces. So grade 1 degenerative spondyes that are reasonably stable, it's probably preferable to do these procedures. Just wanted to give you a final complication of these. This is an 80-year-old radiologist who I did a single level decompression with a stabilization. And 5 years later, he was very happy. He came back. He started to develop, quote, some back pain. Being a radiologist, he imaged himself out. The reduction is nice, but he's clearly started to slip forwards more. I asked him again, do you want to have a fusion done? He said, I'll get back to you. So far, he's not gone back to me, but I just wanted to show that follow-up hurts. And again, we don't know what these devices do in the long run, whether they settle in, whether there's a spinous process, loosening or breakage. He was thrilled for 4 years. Now he's 85. He's not going away. He came back to clinic. So this is just a message, and we'll go to the lab for the grand finale with our chairman. I personally postulate that human beings are more than a math problem and a trigonometry equation. We should probably, and I will venture to that, and it was so nice to hear Dr. Shafi say the same thing, without any form of coordination, we should reconsider fusions. I mean, when I ask people for grade 1 degenerative spondylolistheses and suggest a decompression only or a decompression stabilization procedure, whatever your technique is, they all want to fuse. And again, industry is making it easy and easy to fuse. Billing wise, we earn way more for a fusion. But if we do it, we should really think about it heavily, and we should flawlessly execute. And that means, especially after this meeting, reestablishing alignments. And again, consider decompression and stabilization surgeries, because patients are wising up that fusions beget more fusions. And motion preservation may actually be the new minimally invasive surgery, not the soft tissue sparing approaches that go through muscle tissues frequently, but having something that allows for a safe motion preservation may be a far better fit for a lot of patients. Congratulations on this meeting, and any thoughts, questions? Chris, commentary?
No, I think that that what the thoughtfulness that you've put into this is excellent, and I think that again, where we get ourselves in trouble, I think that for a straightforward degenerative spondylolisthesis, I think the device you show unquestionably works. It's just how much deformity, how much coronal plane deformity you can put up with and have them still work. As I think people like you and others who do things in a very thoughtful and honest way is really something that's going to be helpful.
Good. Thank you for this commentary. Dr. Lewis, are you ready in the lab?